patient is crashing in your ICU bed. They were admitted with severe acute respiratory distress syndrome, and it's escalating rapidly into vasopressor refractory shock.
Right.
You've initiated lung protective ventilation, prone positioning, and you've blanketed them with the absolute heaviest broad-spectrum antibacterials in the formulary.
Covering MRSA, Pseudomonas, the atypicals, all of it.
Exactly. But the cultures are sterile, the lactate is climbing, they are dying right in front of you. And the cognitive trap here is assuming you're dealing with some highly resistant modern superbug.
Yeah, that's the immediate instinct.
But the clinical reality, especially with the epidemiological shifts we're seeing right now in 2025 and 2026, is that the culprit is likely an ancient, highly evolved pathogen exploiting a massive diagnostic blind spot. We are talking about tuberculosis.
The scenario you just described, I mean, that is the defining clinical crisis for infectious disease in critical care right now. When clinicians anchor on rapid, acute bacterial pyogenesis, they completely miss the slow, destructive architecture of granulomatous disease until it reaches catastrophic physiological collapse. We're missing the diagnosis upstream, and we are paying the price in the intensive care unit.
Well, welcome to this deep dive. Today we are speaking directly to you, the critical care physicians, infectious disease specialists, and advanced practitioners on the front lines.
Absolutely.
We're bypassing the foundational reviews today. Our mission is to provide a mechanism-driven, clinically actionable breakdown of tuberculosis, specifically designed to rewire your real-time bedside decision-making.
And to do that, we are drawing from the latest 2025 and 2026 clinical guidelines. Specifically, we're unpacking the masterclass, Not Missing Tuberculosis, and the Tuberculosis Master Chapter for adult clinicians.
And, before we look at that crashing patient we just talked about, we have to understand why they are crashing in the first place.
Right, because in modern ICUs, TB emergencies are almost always the result of a catastrophic upstream failure.
The diagnostic delay.
Exactly. The data absolutely dictates that we treat this as a frontline threat. I mean, the World Health Organization's recent epidemiological surveillance documented 10.7 million global cases.
Wow.
With 1.23 million deaths. And we are still dealing with the long-tail recovery from all those pandemic-era disruptions to the public health infrastructure.
Yeah, the provisional 2025 data for the United States, it shows 10,260 reported cases.
Right, which is a rate of 3.0 per 100,000 population. And that distribution is heavily skewed toward high-burden states, California, Texas, New York, Florida.
And isn't it like 77% of the U.S. burden is in non-U.S. born individuals?
It is, yeah. But the metric that really demands our attention, the one that drives this entire ICU crisis, is the median total diagnostic delay.
30 days?
30 days. We have patients bouncing between primary care clinics, urgent care centers, and EDs with what gets mischaracterized as a smoldering community-acquired pneumonia.
Right. They fail a trial of azithromycin.
Exactly. They return a week later, they get levofloxacin, they fail again, and they just continue to deteriorate while actively aerosolizing bacilli into crowded waiting rooms.
Ooh, but, if I'm a clinician working in a low-incidence area, isn't it statistically safer to assume it's just a stubborn bacterial pneumonia? Like, why jump to TB?
Well, that delay is fueled by exactly that mindset. It's what the masterclass terms the myth of the necessary exposure. Clinicians falsely believe they can stratify risk based on a patient's social history.
They ask, do you know anyone with TB?
Yes. And when the patient says no, the clinician just mentally crosses mycobacterial disease right off the differential.
Which is clinically absurd, right? Because relying on a patient to recall an aerosolized exposure, the initial inoculation could have happened 40 years ago in another country.
Or 4 weeks ago in a poorly ventilated nursing home or unhoused shelter in the clinician's own city. The bacillus operates as an invisible aerosol. Patients do not know when they inhale a 2-micron droplet nucleus.
And we're seeing a significant rise in incidence among adults over 65, too.
Right, and that isn't necessarily new transmission. This is immunosenescence. T-cell memory established in, say, the mid-20th century is degrading, and it's unmasking latent infections from 50 years prior.
So if you wait for a confirmed exposure history to initiate airborne isolation and order molecular diagnostics, you will invariably expose your entire ICU staff during an aerosol-generating procedure, like intubation.
You'll expose everyone. So let's just briefly recap this epidemiology because it's so critical.
Please.
We have over 10 million global cases, rising rates in older adults due to immune waning, and a deadly median diagnostic delay of 30 days. Relying on a known exposure history is a fatal error that drives patients straight into the ICU.
Okay, so let's track the pathophysiology during that 30-day delay,
Right.
because we need to understand the molecular mechanics of how the bacillus evades the initial innate immune response.
Right.
The patient inhales droplet nuclei containing Mycobacterium tuberculosis. Because these droplets are tiny, between 1 and 5 microns, they bypass the turbulent mucociliary escalator of the proximal airways.
They drop directly into the terminal alveoli, typically favoring the well-ventilated mid to lower lung zones.
And the immediate host response is that the resident alveolar macrophage basically eats it. It phagocytoses the bacilli.
Exactly. Now, in a standard bacterial infection, this initiates a rapid cascade. The phagosome fuses with the lysosome, dropping the internal pH and exposing the pathogen to reactive oxygen species and proteolytic enzymes.
And the infection is cleared before the adaptive immune system even knows what happened.
Right. But MTB deploys what is essentially a biological rootkit. It doesn't just survive the macrophage, it actively rewires the host cell's intracellular trafficking machinery.
I like to compare the macrophage to a high-security prison. And the prisoner, the MTB, immediately rewires the security system and turns it into a luxury hotel.
That's a great analogy.
Hey, let's unpack this. How exactly does it pull off this heist?
Well, the primary mechanism of this subversion involves a secreted lipid phosphatase called SAPM. Right. MTB secretes SAPM directly into the host cytosol to hydrolyze phosphatidylacetyl 3-phosphate, or PI3P, which is located on the phagosomal membrane.
And PI3P is the critical signaling molecule required for the recruitment of early endosome antigen 1, right?
Exactly. Without PI3P, the phagosome physically cannot tether to or fuse with the late endosome. The entire maturation process is just arrested.
So the lysosomal acid is never delivered?
Never delivered. The pathogen secures a protected intracellular niche, and the sources detail an additional layer of defense involving the taco protein.
Oh yeah, the tryptophan aspartate containing coat protein.
MTB actively recruits and retains taco on the surface of its phagosome. So this host protein acts as a physical barrier, further preventing lysosomal docking.
Wow.
But the evasion strategies, they extend way beyond physical barriers into direct transcriptional interference. The bacterium secretes a virulence factor known as RV1435C.
Also known as host splicing regulator 1. This is where the pathogenesis literally mimics a cyber attack.
It really does. RV1435C interacts directly with the U5 small nuclear RNA of the host macrophage's spliceosome.
So it's messing with the host's genetic splicing.
Exactly. By binding to the spliceosome, the bacillus induces targeted exon skipping in the host's mRNA. It literally scrambles the genetic code required to mount an antibacterial transcriptional response.
So the macrophage is infected, but its internal signaling networks are suppressed. It can't sound the alarm to the surrounding immune architecture.
Precisely. The bacillus replicates silently within this hijacked macrophage until the cell bursts, releasing a higher burden of mycobacteria into the alveolar space.
And this unchecked replication continues for roughly 2 to 8 weeks before the adaptive immune response, specifically the CD4 plus Th1 lymphocytes, finally migrates to the site.
And when those Th1 cells arrive, they radically alter the tissue microenvironment. They secrete massive quantities of interferon gamma and TNF-alpha, activating the surrounding macrophages.
Right, and those macrophages undergo a profound phenotypic shift.
Yeah.
They differentiate into epithelioid cells, they fuse into multinucleated giant cells, and they form the granuloma.
And this is where traditional pathology teaching completely misleads us.
How so?
Because the traditional curriculum frames the granuloma as a static, protective, calcified wall, like a successful containment of the threat. But the modern immunological understanding completely contradicts this.
Right. The masterclass emphasizes that the granuloma is an incredibly volatile, dynamic battlefield.
Highly volatile. Its structural integrity requires constant active maintenance driven by a superfragile equilibrium of TNF, interleukin-12, and hypoxia-inducible factor 1 alpha, or HIF-1A.
And the core of the granuloma becomes profoundly hypoxic.
Yes, the bacilli are not eliminated. They are forced into a dormant, non-replicating state by nutrient starvation and low oxygen tension.
Okay, this brings us to a really pivotal transition in the disease process. The shift from cellular containment to massive structural destruction. Because when that immune equilibrium fails, the solid cellular mass undergoes caseous necrosis.
The center degrades into this acidic, acellular debris. But caseous necrosis alone doesn't drive transmission. The epidemiological disaster happens during liquefaction.
Right. Host macrophages and recruited neutrophils start reacting to the dysregulated environment, and they release massive quantities of matrix metalloproteinases.
Specifically MMP1 and MMP9. These are zinc-dependent endopeptidases.
Now, here's where it gets really interesting and horrifying. It's not the bacteria directly eating the lung. It's our own immune system dissolving the structural collagen, right?
Exactly. MMP1 is a highly potent collagenase. The lung parenchyma is structurally supported by a fibrillar collagen matrix, primarily type I and type 3 collagen.
Yeah.
The immune system's release of MMP1 systematically cleaves this collagen scaffolding. We are literally witnessing the host's own inflammatory response dissolving the architectural matrix of the lung.
And so the solid caseum liquefies into a highly infectious fluid. As the collagen degrades, this necrotic core physically erodes right through the wall of an adjacent bronchial airway.
And the patient expectorates this liquefied debris, leaving behind a hollow parenchymal void. The cavity is born.
And the formation of the cavity is like the ultimate evolutionary objective of the bacillus, because Mycobacterium tuberculosis is an obligate aerobe.
Right. For months, it has been suffocating inside a hypoxic granuloma. The erosion into the bronchial tree provides this sudden, massive influx of oxygen.
And that oxygen exposure triggers an explosive logarithmic replication phase. The masterclass sources point out that the bacillary load within a mature cavity can reach 10 to the 11th power $10 from a gram of tissue.
It's a staggering. At $10 bacilli per gram, the patient transitions into a superspreader. Every single cough aerosolizes millions of infectious droplet nuclei.
Wow.
So just to give a quick micro recap here, intracellular survival is driven by SAPM and TACO blocking the lysosome. Then the catastrophic transition from a solid granuloma to a cavity is mediated by host MMP1 liquefying the tissue. And it's that sudden oxygen exposure that drives the explosive bacillary load.
Which fundamentally challenges the pervasive myth of the immunocompetent host.
Yeah.
We routinely encounter clinical teams dismissing TB in young, seemingly healthy patients presenting with bilateral cavitary disease simply because their HIV test is negative.
Or because they aren't on immunosuppressive biologics. Yeah, that binary concept of immunocompetence is clinically dangerous.
Totally.
Host vulnerability exists on a really complex spectrum. It's heavily influenced by highly prevalent metabolic and environmental modifiers. Diabetes mellitus is probably the most prominent example.
Right, because in the context of mycobacterial infection, diabetes is a profound state of immune dysregulation.
Absolutely. Hyperglycemia and the accumulation of advanced glycation end products severely impair macrophage chemotaxis. It blunts the respiratory burst, and it completely dysregulates MP expression.
So the macrophages in a diabetic patient are sluggish, which heavily delays that initial Th1 response we talked about.
Yes, and that delay allows for a much higher bacillary burden before granuloma formation even has a chance to begin.
And then you add in things like chronic kidney disease, which induces uremia-associated T-cell dysfunction, or heavy tobacco smoking.
Oh, smoking is massive. It paralyzes mucociliary clearance and heavily carbon loads the alveolar macrophages, which physically impedes their phagocytic capacity.
Even general undernutrition deprives the immune system of essential substrates, like zinc and vitamin D, which are required for macrophage activation.
Exactly.
But what if the patient has absolutely zero comorbidities, like they run marathons, they eat clean? Can they still get bilateral cavities?
Yes, they absolutely can. And this forces us to look beyond the host and examine pathogen virulence. The global dissemination of the modern Beijing sublineage of MTB is a crucial factor here.
The Beijing strain.
Right. This particular strain demonstrates significant hypervirulence. It synthesizes specific phenolic glycolipids that allow it to bypass early innate immune detection.
And once the adaptive response finally engages, the Beijing strain induces a massive hyperinflammatory reaction, right?
It does. It drives rapid lipid accumulation within macrophages, creating these foamy cells, and it provokes an excessive, localized cytokine storm, regardless of the host's baseline immunological health.
Wow. So you do not need systemic immune collapse to develop severe cavitary TB. You just need a hyperinflammatory host-pathogen mismatch, where the host's exuberant MMP response destroys its own tissue.
That's all it takes. And this hyperinflammatory, tissue-destroying biology directly informs the radiologic phenotypes we see at the bedside.
Which brings us to the radiology masterclass section. Because if clinicians rely on the classic apical cavity chest radiograph, they will systematically underdiagnose the disease.
High-resolution CT, or HRCT, is mandatory for accurate pattern recognition. The data is definitive on this point.
Right, the sources note that up to 36.7% of clinically immunocompetent patients and 76.7% of compromised hosts present with radiologic features that deviate from the classic apical fibrocavitary pattern.
Right. We frequently encounter lower lobe consolidation that flawlessly mimics bacterial community-acquired pneumonia.
A dense right lower lobe consolidation in a diabetic patient. The clinician anchors on the lower lobe location, assumes it's pneumococcal, and rules out TB.
Happens all the time. But the HRCT reveals the subtle hallmarks of mycobacterial spread, specifically the tree and bud opacity.
Let's break down tree and bud. I imagine it like a clogged highway system at the very edges of a city. It's the infectious caseous material backing up into the distal bronchioles.
That's exactly what it is. Tree and bud is the radiologic signature of active endobronchial spread.
Right.
As the liquefied caseum from a cavity or a necrotic node empties into a proximal airway, the patient aspirates this infectious material right into the distal bronchioles.
And the material impacts the terminal bronchioles, causing them to dilate and fill with mucus and pus. So on a CT scan, these clogged, branching distal airways look exactly like the budding branches of a tree in springtime.
Exactly. When you identify a tree and bud pattern that fails to resolve after standard broad-spectrum antibacterial therapy, mycobacterial disease must be your primary working diagnosis.
But interpreting these HRCT patterns requires a really meticulous differential diagnosis to avoid catastrophic iatrogenic errors. And the most dangerous radiologic mimic out there is sarcoidosis.
Oh, absolutely. Both sarcoidosis and TB are granulomatous diseases. Both cause weight loss, night sweats, and they both favor the upper lobes.
But the pathology and the radiologic distribution have distinct differences. Sarcoidosis typically generates non-caseating granulomas and presents with bilateral, symmetric hilar adenopathy.
Right. Radiologically, sarcoidosis nodules follow a paralymphatic distribution. They aggregate along the pleural certivus, the interlobar fissures, and the bronchorvascular bundles, often coalescing into what we call the galaxy sign.
Whereas tuberculosis produces caseating granulomas, unilateral or necrotic adenopathy, and it favors a centrolobular distribution.
Which includes the tree and bud pattern.
And the critical warning here, which is highlighted extensively in the source material, is that up to 1/3 of severe sarcoidosis biopsies can exhibit some necrotic features.
Yes. And if a pathologist overcalls that necrosis, or if a clinician initiates treatment based purely on a presumed sarcoid radiologic pattern without definitively ruling out TB via molecular testing.
They gave high-dose systemic corticosteroids, which is the standard of care for sarcoid.
And administering high-dose steroids to a patient with unrecognized active tuberculosis will absolutely obliterate the fragile Th1-mediated containment we discussed earlier.
The granulomas just disintegrate.
They disintegrate rapidly, leading to massive, frequently fatal hematogenous dissemination of the mycobacteria. It is a fatal error.
So dangerous. Another critical mimic is granulomatosis with polyangiitis, or GPA, formerly regions. GPA routinely presents with bilateral cavitary lung lesions and hemoptysis.
Right, but GPA cavities often demonstrate thicker, more irregular walls during their initial phase. And more importantly, GPA lacks the satellite tree and bud opacities indicative of endobronchial spread.
And the clinical picture will point away from infection. These patients typically have rapidly progressive glomerulonephritis, and their serology will be heavily CANCA positive.
Exactly.
Yeah.
We also have to differentiate primary lung malignancy, specifically squamous cell carcinoma.
Right, which often presents as a thick, spiculated upper lobe mass with central necrosis. And the trap here is demographic anchoring.
A physician sees a 60-year-old heavy smoker with a 4-centimeter upper lobe mass and immediately locks onto malignancy. They completely ignore the possibility of a tuberculoma.
And tuberculomas are solid, mass-like granulomas that perfectly mimic neoplastic processes on imaging.
They do. And if the patient is sent for a percutaneous biopsy without the proceduralist securing tissue for mycobacterial culture, the diagnosis will be missed entirely.
Finally, we have non-tuberculous mycobacteria, or NTM, such as the Mycobacterium avium complex.
Right. NTM produces tree and bud and cavitary disease, but it heavily favors the mid and lower lung zones. That's the classic Lady Windermere syndrome phenotype.
And it's predominantly seen in older hosts with pre-existing architectural damage, like bronchiectasis.
So to do a quick micro recap of this section, remember that subtle host modifiers like diabetes and smoking drive disease severity.
Right.
The HRCT protocol is mandatory. Tree and bud means active spread, and confusing TB with sarcoidosis and giving steroids can be a fatal mistake.
So we've focused heavily on the lungs. But this complex diagnostic landscape extends far beyond the pulmonary system. We have to account for extrapulmonary manifestations.
Absolutely. Because during the initial primary infection, a transient subclinical bacteremia occurs. The bacillus enters the bloodstream and seeds multiple organ systems, lying dormant for decades before reactivating.
And when it reactivates outside the lungs, it acts as a flawless mimic for other specialties' core diseases.
The most lethal of these manifestations is central nervous system tuberculosis, specifically tuberculous meningitis.
And the presentation there is subacute, right? It develops over weeks, not hours.
Exactly, which clinically distinguishes it from the rapid fulminant collapse you see in meningococcal or pneumococcal meningitis. Patients present with escalating headaches, low-grade fevers, cranial nerve palsies, particularly cranial nerve VI, and a slow decline in sensorium.
And the pathophysiology driving this is the rupture of a subpial granuloma, known as a rich focus, directly into the subarachnoid space.
Right. That triggers an intense inflammatory response, generating this thick, gelatinous exudate that preferentially pools at the base of the brain.
And that basilar exudate envelops the circle of Willis, causing an infectious vasculitis of the lenticulostriate arteries, which frequently results in massive basal ganglia infarctions.
It also mechanically obstructs the arachnoid granulations, leading to communicating hydrocephalus.
So how do we diagnose it?
The diagnostic key is the lumbar puncture. The CSF profile demonstrates a highly specific triad. First, a lymphocytic predominant pleocytosis, typically between 100 and 500 cells per microliter. Second, a significantly elevated protein level, often exceeding 1 gram per liter due to the breakdown of the blood-brain barrier.
And third.
Severe hypoglycemia. We are looking for a CSF to plasma glucose ratio of less than 0.5.
Less than 0.5, got it. Moving down to the renal system, genitourinary TB arises from that same early hematogenous seeding, specifically targeting the highly vascular renal cortex.
And the classic board-testable manifestation here is sterile pyuria. The patient presents with dysuria, frequency, and flank pain.
And the urinalysis reveals like 50 to 100 white blood cells per high-power field, indicating severe inflammation. But the standard aerobic bacterial cultures return completely negative.
Right, but the clinical reality is often muddied by secondary bacterial superinfections. A patient with underlying GUTB may present with a concomitant E. coli UTI.
Oh, that's tricky.
Very. The clinician treats the E. coli, the acute symptoms partially resolve, but the underlying mycobacterial infection continues to silently destroy the renal parenchyma,
Eventually causing papillary necrosis and fibrotic contraction of the bladder, the so-called thimble bladder.
Exactly. Then there's musculoskeletal involvement, particularly spinal TB or pot disease. This presents another massive diagnostic challenge.
MTB preferentially seeds the anterior aspect of the vertebral bodies, particularly in the lower thoracic and lumbar spine, because of the dense venous plexus there.
And the infection slowly destroys the intervertebral disc space and causes anterior wedge compression fractures.
This mechanical collapse is what results in the sharp kyphotic bending of the spine known as a gibbous deformity. But here's my question. Will their chest x-ray show TB?
That is the ultimate diagnostic trap. Less than 20% of patients with active pot disease have concurrent active pulmonary disease at presentation.
Wow, less than 20%.
Their chest radiographs are pristine, so severe back pain in an elderly patient is just dismissed as osteoporotic compression fractures or routine degenerative disc disease.
Until an MRI reveals extensive vertebral destruction and paraspinal cold abscesses.
Right, those collections of liquefied caesium that lack the profound erythema and heat of a pyogenic staph infection.
And finally, gastrointestinal TB further complicates the picture by acting as a flawless mimic for Crohn's disease.
It really does. MTB heavily localizes to the ileocecal junction, causing right lower quadrant pain, chronic diarrhea, and weight loss.
And CT imaging demonstrates asymmetric bowel wall thickening, strictures, and necrotic intra-abdominal lymphadenopathy.
If the infection disseminates into the peritoneal cavity, it generates an exudate of ascites characterized by a high serum ascites albumin gradient and elevated adenosine deaminase, or ADA.
But because GITB is inherently paucibacillary, having a very low bacterial burden fluid smears are routinely negative.
Which means differentiating this from a Crohn's flare requires an endoscopic tissue biopsy demonstrating case-eating granulomas before the catastrophic error of prescribing anti-TNF biologic agents is made.
Right, because if you give anti-TNF agents to a patient with active TB,
it's game over. Rapid dissemination.
Which brings us back to the crashing patient in the introduction. How do these delayed complex phenotypes present in the intensive care unit?
We need to detail the four major ICU syndromes associated with end-stage tuberculosis, starting with TB-associated ARD.
TB-ARD is predominantly driven by diffuse miliary dissemination. The hematogenous spread of massive quantities of bacillia overwhelms the pulmonary capillary bed.
Triggering diffuse alveolar damage and profound hyaline membrane formation. Even in highly endemic ICUs, TB accounts for only about 4 to 5% of all ARDS cases.
But the mortality rate is staggering, right? Often exceeding 60 to 70%.
Yes, and managing mechanical ventilation in these patients is incredibly precarious.
Because if the patient has concurrent cavitary disease, utilizing high positive end expiratory pressure, or PEEP, risks rupturing the cavity.
Exactly. You create a massive bronchopleural fistula or a lethal tension pneumothorax.
So that's ARDS. The second syndrome is highly dissective septic shock.
Historically, we associate septic shock with gram-negative endotoxins. However, MTB possesses a potent cell wall component called liporabinomannan, or LAM.
Right, LAM.
In disseminated disease, LAM massively interacts with host toll-like receptors, triggering a systemic macrophage activation syndrome.
So it creates a cytokine storm characterized by profound elevations in IL-6 and TNF-alpha that is clinically indistinguishable from standard bacterial sepsis.
The patient presents profoundly hypotensive, tachycardic, and with an escalating lactate, yet continuous blood cultures return sterile.
The third ICU syndrome is a purely mechanical catastrophe, massive hemoptysis.
As a cavitary lesion expands, the intense localized inflammation can physically erode into an adjacent high-pressure bronchial artery.
This erosion weakens the arterial wall, generating a pseudoaneurysm known as a Rasmussen's aneurysm.
When that pseudoaneurysm ruptures, the hemorrhage into the airway is sudden, massive, and catastrophic.
And the mechanism of death here is asphyxiation, not exsanguination. The unaffected lung simply floods with arterial blood, completely obstructing gas exchange.
Immediate aggressive intervention is mandatory. The airway must be secured, frequently requiring selective intubation of the unaffected mainstem bronchus.
And you must position the patient bleeding side down to utilize gravity to protect the functional lung.
Simultaneously, interventional radiology must be mobilized for emergent bronchial artery embolization to mechanically occlude the bleeding vessel.
The fourth critical care syndrome is adrenal crisis. This is the result of direct granulomatous destruction of the bilateral adrenal cortices by the mycobacteria,
leading to an insidious Addisonian state. In the stress of the ICU, this manifests as vasopressor refractory shock.
Right. The patient's systemic vascular resistance plummets, and escalating doses of norepinephrine have zero physiological effect.
Because there is an absolute lack of endogenous cortisol required to maintain alpha receptor sensitivity. Identifying this requires immediate administration of stress dose intravenous hydrocortisone.
Let's do a quick micro recap here before we move on.
Sure.
Extrapulmonary flags include CSF glucose less than 0.5 and sterile pyuria. And in the ICU, we have TB-ARDS where PEEP is dangerous, LAM-mediated sterile shock, massive hemoptysis requiring bleeding side-down positioning, and adrenal crisis needing hydrocortisone.
Spot on. Now, navigating these critical presentations requires an executive-level diagnostic strategy. The era of initiating a Lowenstein-Jensen culture and waiting 6 weeks for colony growth to make clinical decisions is completely obsolete.
Modern diagnostics are entirely dependent on the nucleic acid amplification test, or NET8 revolution. And the current absolute standard of care is the GenExpert MTB-IF Ultra assay.
The GenExpert Ultra. It's a cartridge-based, nested real-time PCR that simultaneously detects mycobacterial DNA and mutations in the ARPO-B gene, which confer resistance to rifampin.
And the Ultra version has significantly lowered the limit of detection down to just 16 colony-forming units per milliliter. It provides definitive results in under 2 hours.
For pulmonary disease, the protocol mandates the collection of 3 distinct sputum specimens, spaced 8 to 24 hours apart,
with at least one early morning sample. And the timing here is not arbitrary. Cage's material is shed intermittently from the bronchial tree, and respiratory secretions pool in the airways overnight.
So the early morning sample is the most concentrated and highest yield. While all 3 samples are sent for acid-fast bacilli smear and mycobacterial culture, a NAT must be run on the initial specimen immediately.
Because smears require a bacterial load of approximately 10,000 bacilli per milliliter to turn positive, meaning they have terrible sensitivity.
Terrible. Relying solely on a negative smear to discontinue isolation protocols is a major infection control violation.
What if the patient is intubated or lacks a productive cough?
We attempt hypertonic saline-induced sputum. If non-invasive measures fail and clinical suspicion remains high, like a patient with unexplained tree and bud opacities, we must escalate to bronchoscopy.
With bronchoalveolar lavage fluid sent for GenExpert Ultra.
Exactly. Now, extrapulmonary diagnostics require specific sample optimization. Because extrapulmonary sites are possibacillary, a standard 1 milliliter tube of CSF will frequently return a false negative for TB meningitis.
The lab needs a high-volume sample, greater than 5 to 10 milliliters of CSF to centrifuge and concentrate for the GenExpert assay.
For genitourinary TB, urinate has vastly outperformed traditional urine mycobacterial cultures.
Pleural fluid, however, remains notoriously difficult. Both smear and culture yields from pleural fluid are dismal.
Diagnosis of pleural TB often hinges on identifying elevated adenosine deaminase levels in the fluid, noting a lymphocyte-predominant exudate, or proceeding to a closed pleural biopsy to identify caseating granulomas.
Which brings us to a massive medical legal warning regarding tissue handling. If a surgeon or pulmonologist biopsies a lymph node, pleural tissue, or a suspected tuberculoma, the specimen must never be entirely submerged in formalin.
Never. Formalin physically cross-links the tissue proteins, completely neutralizing the mycobacteria. It destroys the ability to culture the organism for phenotypic drug susceptibility testing.
So the tissue must be divided. A portion in formalin for the pathologist, and a portion sent fresh or in sterile saline directly to the microbiology lab.
Once the diagnosis is secured, the treatment phase begins. And we must specifically address the 2025-2026 guidelines regarding the adjunctive use of corticosteroids.
Right, because we previously detailed how the immune system's structural destruction of the host drives the pathology. Therefore, strategically suppressing that immune response is vital in specific clinical scenarios.
A 2025 systematic review confirmed a definitive mortality benefit for the use of dexamethasone or prednisolone in TB meningitis.
The high-dose steroids suppress the catastrophic intracranial inflammation, reducing the basilar exudate, minimizing the risk of vasculitic strokes, and mitigating hydrocephalus.
The dexamethasone is typically initiated immediately and tapered slowly over 6 to 8 weeks.
Corticosteroids are also utilized in TB pericarditis to prevent the intense inflammatory response from progressing into a fibrotic constrictive pericarditis.
Though the mortality benefit there is less pronounced than in CNS disease. Additionally, in patients living with HIV who are initiating antiretroviral therapy, a prophylactic 4-week course of prednisolone significantly reduces the incidence of paradoxical TB iris.
Immune reconstitution inflammatory syndrome.
Exactly.
To synthesize this masterclass, we really need to examine 3 specific clinical cases from the source material that highlight the cognitive traps leading to massive medical, legal, and clinical errors.
Let's do it.
Case 1 is the bacterial pneumonia that wouldn't resolve. A 45-year-old male with poorly controlled diabetes presents with a dense right lower lobe consolidation.
Right.
He fails sequential courses of azithromycin, levofloxacin, and amoxicillin clavulinate over 6 weeks.
Right. And the clinical presentation perfectly aligns with tuberculosis because lower lobe disease is incredibly common in diabetic patients whose macrophage chemotaxis is impaired.
But the diagnosis was missed because the clinician anchored on the lack of an apical cavity, assuming TB must present in the upper lobes.
The non-negotiable protocol here is that any pulmonary infiltrate failing to resolve after 2 standard courses of broad-spectrum antibiotics mandates a molecular TB workup, period.
Case 2, the asthmatic.
Yeah.
A 30-year-old patient presents with what is misclassified as refractory asthma. They exhibit chronic, diffuse wheezing. An HRCT reveals centrilobular nodules and branching tree and bud opacities.
The endobronchial spread of mycobacteria severely irritates and physically obstructs the distal bronchioles, which flawlessly mimics the expiratory wheeze of asthma.
And the radiologist misread the tree and bud pattern as severe viral bronchitis or chronic aspiration, heavily influenced by the clinical label of asthma.
The trigger for intervention is clear. Tree and bud opacities in a symptomatic patient represent active mycobacterial spread until proven otherwise by a NET.
Case 3, the lung cancer surprise. A 55-year-old heavy smoker presents with significant weight loss and a 3-centimeter spiculated mass in the right upper lobe.
This is a classic tuberculoma. The physician fell victim to demographic anchoring, seeing an older smoker with an upper lobe mass and instantly assuming squamous cell carcinoma.
They pursued a biopsy exclusively for malignancy. The critical save here is the pathologist identifying caseating granulomas, provided the proceduralist actually remembered to send fresh tissue for culture.
Right. And a major trap associated with all these complex cases is the misuse of immunological testing.
Oh, this is so important. Clinicians frequently order an interferon gamma release assay, an IGRA, or a tuberculin skin test to rule out active disease in severely ill patients.
Which is a fundamental misunderstanding of the tests. IGRAs and skin tests only measure the presence of T-cell memory regarding a prior mycobacterial exposure.
Right, they cannot distinguish between latent infection and active destructive disease.
A positive IGRA in a patient with a new cavitary lesion does not confirm TB. They could just have latent TB from childhood and a new primary lung adenocarcinoma.
Conversely, and much more dangerously, a negative IGRA does not rule out active tuberculosis in a crashing ICU patient.
No, it doesn't. In cases of overwhelming miliary dissemination, the host's immune system enters a state of profound exhaustion, known as anergy.
The T cells are too depleted to synthesize the interferon gamma required to trigger a positive assay.
The test returns negative, the clinician prematurely crosses TB off the differential, and the patient succumbs to ARDS.
Which brings us to the ultimate failure in clinical management, the failure to isolate.
Yes. Allowing a patient with an unexplained cavitary lesion, chronic cough, or tree and bud opacities to remain in an open emergency department bay or a standard medical ward while awaiting the results of a levofloxacin trial. It is an infection control disaster.
If the HRCT demonstrates tree and bud, cavitation, or miliary nodules, the patient must be immediately transferred to an airborne infection isolation room with negative pressure ventilation.
You secure the isolation first, then you order the GenExpert Ultra to confirm or refute your suspicion.
So as we wrap up this deep dive, the final master synthesis, the core message you need to take away is, do not wait for the classic presentation. Atypical is the new typical.
The pathogen survival is predicated on mimicking mundane pathologies, refractory pneumonia, new-onset asthma, Crohn's disease, culture-negative UTIs.
We must trust the underlying mechanisms. We have to recognize how subtle metabolic modifiers like diabetes facilitate immune escape, and how hypervirulent strains like the Beijing lineage induce host MMPs to liquefy the lung matrix.
We must secure aggressive molecular diagnostics from the affected compartments, and above all, prioritize immediate airborne isolation.
And we must acknowledge the post-diagnostic reality. Once the patient is cured microbiologically, they are left with destroyed lung architecture.
Achieving microbiological cure with 6 months of rifampin-based therapy eliminates the bacillus, but it does not reverse the profound structural destruction.
Massive cavitary burden leaves the patient with permanently destroyed lung parenchyma, severe traction bronchiectasis, and chronic restrictive physiology.
And that architectural damage introduces a secondary long-term threat. Decades after the tuberculosis is cured, the hollow, healed cavities remain in the lung.
Because these cavities communicate directly with the bronchial tree, they provide a sheltered, ventilated microenvironment.
They become the perfect incubator for opportunistic airborne spores.
Which leaves us with our final provocative thought for you to mull over. Decades from now, that healed, empty cavity in the lung could become colonized by an Aspergillus fungal ball.
An aspergilloma.
Right. And years after the TB is long gone, that constantly growing fungal ball can cause mechanical friction against the cavity wall, eventually eroding into the adjacent vasculature and leading to massive, life-threatening hemoptysis.
The shadow of the bacillus outlives the infection itself. The destruction facilitated by the immune system leaves a permanent scar, creating vulnerabilities that echo decades into the patient's future.
Stay vigilant, trust the mechanisms, isolate early, and thank you for joining us on this deep dive.